So, Bismillahirrahmanirrahim. On the behalf of President, Pakistan Society of Hematology, Major General Parvez Ahmed, Thalassemias military, I welcome you all to this first ever webinar arranged by Pakistan Society of Hematology. I agree and admit that COVID-19 has paralyzed most of our activities, but life should go on. So we have planned this continuous medical education activity, and we hope and pray that this CME activity proves beneficial for all of you. As far as COVID is concerned, I would just like to narrate few verses. Sir Irfan की फरमाइश पे, मैं मानता हूँ कि वबा के दिन है, मैं मानता हूँ कि वबा के दिन है, मगर ये दिन भी खुदा के दिन है. दिलों से मायूसियाँ निकालो, जरा से आगे शफा के दिन है. ये पहला मौका नहीं ज़मीन पर, अजीजों ये तो दुआ के दिन है. गुजर गई उम्र गफलतों में, गुजर गई उम्र गफलतों में, यही तो रब से वफा के दिन है. So for this webinar, we have decided the topic of thalassemia, and for next month, we'll be speaking upon hematological aspects of COVID-19, inshallah. We have invited renowned experts from all over the country for putting their the audience wiser on their respective subjects. So we have 4 panelists. I would appreciate if Imran highlights the panelists. First of all, first and foremost, my own teacher, my mentor, a big name in thalassemia, and the only name in the prenatal diagnosis and genetics of thalassemia, Major General Suhaib Ahmed, Thalassemias military. Presently, he is Chief Executive Officer of Genetics Resource Center and working in Rawalpindi. The second panelist is another very good teacher from Karachi, a very experienced hematologist, professor of hematology and head of the Department of Hematology at Liaquat National Hospital. He has special interest in thalassemias and transfusion, along with many other subjects of hematology. Our third panelist is from Lahore, Professor Dr. Adil Akhtar, a very competent pediatrician with a special interest in thalassemias. He was associate professor of pediatrics in Fatma Jinnah Medical University and currently associate director of neonatal and child health program at Global Health Directorate of Indus Health Services. And last but not the least, from my very own Institute Armed Forces Bone Marrow Transplant Center and National Institute of Blood and Marrow Transplant, Colonel Dr. Tariq Ghafoor. He is professor of pediatric oncology and undoubtedly the most experienced pediatric oncologist and pediatric transplant physicians of the country. So we are very thankful to all the 4 panelists for sparing their precious time. Now I hand over to President, Pakistan Society of Hematology, Major General Parvez Ahmed, for his welcome address, followed by General Suhaib's talk. Thank you very much.
Bismillahirrahmanirrahim. Welcome everybody to this first PSH webinar. As Dr. Mehreen has explained, that with the onset of COVID-19 pandemic, everything had gone into standstill, including all the academic activities. And now there is realization that we have to live with this virus at least for the near future. And keeping in view this realization, we from the forum of PSH has planned CME activities on all the important aspects of hematology over next 12 months, inshallah. This is the first webinar on the subject of thalassemia. And we have chosen the subject of thalassemia since it is the most common inherited genetic disorder in Pakistan. All the speakers, they have already been introduced. They have got not only the expertise, they have got practical experience in their respective fields. And as we know, once you encountered a patient, you have to translate your theoretical knowledge into your practical skills. You have to apply all these to come to a diagnosis and management of that particular patient. And here is the point that these panelists, these speakers, they have got their expertise. They'll be telling you the practical points, keeping in view the realities and facilities available in this country. And I wish you a rewarding academic activity over the next 2 hours, inshallah. Thank you.
Thank you very much, sir. So I invite my mentor, Janab Suhaib Ahmed, for his first talk on the diagnosis of thalassemia. Sir, kindly share your slides and take over. Thank you.
Thank you very much, Mehreen and Parvez, for this opportunity. I think it's a wonderful effort. And let's go to the topic. Time is short, in 20 minutes. Yeah. Okay, in this very brief period, I'll try to give you an overview of diagnosis of thalassemia. I assume that everyone knows what is thalassemia and what so basically, there are 3 different situations in which we are supposed to give an answer to what it is. The first scenario is it thalassemia trait or not? This is generally what we come across when we're doing population screening. And the second question is that if there is a child who is presented to us with symptoms of thalassemia, is it thalassaemia major or not? And the third scenario, I think, is another very important aspect, that many times we come across thalassemics who are on or maybe without blood transfusions, and we are asked to give an opinion whether it is Thalassaemia Intermedia or not. Well, these are 3 different scenarios, and the approach to diagnosis also differs in all 3 of them. Now, let's start with question number 1. Is it thalassemia trait or not? The diagnostic approach to such a person who is going to screen for thalassemia trait is different from what it is for thalassemia major. In Pakistan, we know that about 90% of the thalassemia traits, they are typical. They have very typical features. They usually do not have any clinical symptomology. And if you look at the blood film or the blood count, they've got a normal hemoglobin or near to normal hemoglobin. MCV and MCH are low. And if you do electrophoresis, they have a raised hemoglobin. And this is what you see in most of the situations. No problem. Diagnosis is straightforward. But there are about % of the thalassemia traits in which you really have to see beyond what you actually typically see in a thalassemia trait. And sometimes you even have to scratch your head whether it is thalassemia trait or not. Well, why do we need to know exactly whether it is thalassemia trait or not? This is also very important because it's a heritable disease. If you declare someone that he or she doesn't have thalassemia trait, then it actually could create a problem in future for that person. So knowing these 10%, I think, is more important than knowing those 90%. And I'll try to focus on this particular group in which we have siren carriers who do not have any features of thalassemia trait, but still they have thalassemia mutation. And there could be coexisting beta and alpha thalassemia trait. That also masks the picture of a typical thalassemia. And coexisting beta thalassemia trait and abnormal hemoglobins, they also mask the appearance of thalassemia trait. Then iron deficiency, which is also very common, this can also mask the picture of thalassemia trait. So in a typical case, I think MCV and MCH, when it is MCV is less than 75 and MCH is less than 25, we don't have any problem. We suspect thalassemia, and for the definitive test, we do hemoglobin electrophoresis, which gives you a raised hemoglobin A2 beyond 4%. Some labs they cut off at 3.5%. This is just a personal preference. And in some cases, we have to do confirmatory tests when we are not sure whether it is thalassemia trait exactly or not, then we might have to do genetic analysis. There is another test which is called osmotic fragility test. This is also cheap, but this is generally meant for population screening because of the limitation of time has not been taken. So for doing quantitative estimation of hemoglobin fractions, we generally use either cellulose acetate electrophoresis or capillary electrophoresis or HPLC. They're all 3 good techniques. This is the cheapest, and maybe it can be done within about 100 to 200 rupees, and you can measure densitometrically whether the hemoglobin A2 is raised or not. But please remember that in quantitative estimation of hemoglobin fraction, it is the hemoglobin A2 fraction which is most important. We are not really bothered whether hemoglobin F is 90% or 70% or 80% or whatever. But we are bothered because we want to know that whether hemoglobin A2 is above 4% or not. And this is very critical. And it's also important to do this quantitative estimation very accurately. Instrumentary, although it is said that this is not a very accurate method of doing it, but in my experience, if you have the expertise, this is a fairly reliable method. It's cheap. The biggest advantage of this method is that it is very cheap. To look at different fractions, sometimes you have to do qualitative analysis. You can maybe identify abnormal hemoglobins like hemoglobin S or hemoglobin D or hemoglobin F. They can all be identified on cellular electrophoresis. Capillary electrophoresis, that gives you a picture which is more crisper than cellular acetate membrane. But this expensive equipment actually also needs expensive running cost. Generally, one test costs about 700 to 600 rupees, and most people, they really cannot afford such a high cost. The biggest advantage is that you can do, it's an automated procedure. You can do a large number of tests in a very short time. HPLC is another high throughput method in which you can have accurate analysis of different fractions. But I told you that it is the hemoglobin A2 estimation which is most critical. And we want to be very sure whether it is above 4% or it is less than that. And for that, I think all three methods are fairly good. But capillary and HPLC, they are more reliable, but they are expensive. They have to keep it in mind. Now, let's take the case of silent beta thalassemia. In our practice, we generally come across many times a situation in which a child is transfusion dependent. And if we do the study of the parents, we find out that one of the parents has typical beta thalassemia trait, whereas the other parent doesn't have the features of thalassemia. For example, this blood count, it shows that hemoglobin is low, but the NCV and MCH are not low. No, if the child of this person is transfusion dependent, then you really have to think about it and what it is. I think I'll give you the clue about it. If you look at the blood film, generally it is normochromic and normocytic. And when you do electrophoresis, as you can see over here, hemoglobin A2 is not raised. Now, why this child is transfusion dependent, whose parent has a normal blood count, normal blood film, and hemoglobin A2 is normal? Well, if you concentrate on the MCH, it is slightly below what you actually normally expect in a normal person. When you have MCV, which is normal, the MCH is just around 26. This gives you the first clue that this could be a silent thalassemia carrier. And this cannot be identified by any other method than PCR. And if you do PCR, you can identify the mutation. Most of the time in our population, it is Cap+1 mutation, which gives you a picture like this. This is the most dangerous form of thalassemia because it can be easily missed. While you're doing population screening or you're doing screening for thalassemia in your lab or anywhere, any setup, this can be easily missed. But how to identify this, I think this is a long debate. I'll probably don't have enough time for this. But generally, speaking, I think you need to keep in mind that there are carriers who can be completely normal in all aspects. And the only clue that you have over here is borderline MCH, which gives you the first clue that this could be thalassemia, which is silent. When the alpha and beta thalassemia trait, they coexist. And this happens in about 2% of the thalassemia traits. The MCV and MCH, they tend to be normalized. For example, if you expect an MCV of 68 and MCH around something like 80 in a typical thalassemia trait, when it is coexisting with the alpha thalassemia trait, this would be normalized. This would come nearer to normal. And this again becomes a problem. When you're doing population screening based on red cell parameters, then you can actually miss these carriers. Fortunately, most of these individuals, they have raised hemoglobin A2 level. But the important point is that when you're doing a population screening, you can actually miss such carriers. I think these are tricky situations. And sometimes you have to do PCR analysis, especially if you want to recognize the alpha thalassemia component, you have to do it by PCR. Now, another very important, I think, scenario in which many times this has happened with us, that a person comes to us. For example, I remember when I was AFIP, once a child with Thalassaemia Intermedia was brought to us, and we identified that this was Thalassaemia Major. And his father said कि जी मैंने तो शादी से पहले टेस्ट करवाया था और मुझे उन्होंने रिजल्ट ये दिया था कि आपको होमोजाइगस हीमोग्लोबिन डी है और आपको फिर करने की जरूरत नहीं है. This is a catch, I think. Now you look at this electrophoresis, this number 8. This is a single band in the region of hemoglobin D. This is hemoglobin A, this is hemoglobin F, and this is hemoglobin D/S. Now, if you routinely look at such a band, you would tend to give it homozygous hemoglobin D. And this is what exactly happened with that. But if you look back at the red cell indices, you can see that it is hypochromic and microcytic. But remember, when you're doing diagnosis of thalassemia, hypochromia and microcytosis, they are the hallmark of thalassemia. They can be caused because of iron deficiency. But remember that thalassemia also causes hypochromia and microcytosis. In any scenario, in any situation, wherever you see hypochromia and microcytosis, you must at least think of thalassemia. Now, knowing that this is hypochromic and microcytic, now you relook at this one. This is homozygous B with hypochromic and microcytic anemia, or red cell indices at least. But if you look at the hemoglobin A fraction in this particular patient, this is slightly raised. This is above 4%. Now, this is the catch. This is a person who has hemoglobin D on one chromosome and beta thalassemia trait on the other chromosome. This is a combination of hemoglobin D, beta thalassemia. And this can be masked. This beta thalassemia trait can be masked. We know that hemoglobin D is asymptomatic abnormality. It doesn't cause any problem. But when it is in combination with beta thalassemia trait, this person is potentially capable of transmitting its thalassemia to the offspring. And while you are doing population screening, or when you're doing or attempting to screen for thalassemia, I think you need to keep in mind, whenever you come across a person with apparently having a homozygous hemoglobin D, you must look at the red cell indices, and secondly, the hemoglobin A2 fraction. And if you're not really very sure, and if the parents of this individual are available, you can do the screening in the parents, and in one of the parents you will see hemoglobin D, and in the other parent you will see beta thalassemia. And last but not the least, if you have the facility for PCR, you can also look for the mutation of beta thalassemia. So it is important. I think this is another masked type of a thalassemia trait which should not be missed. Well, there are certain thalassemia traits which are more severe than you normally expect. This is another very interesting group, which are more symptomatic. You many times come across patients who have got a report with beta thalassemia trait, but they are slightly jaundiced. The spleen might be slightly enlarged, and they could even have slight anemia. Well, there are many reasons for that. In my experience, this is what I have seen over here in Pakistan. When you have beta thalassemia trait, and at the same time you inherit an additional alpha gene from the other parent, there is a possibility that imbalance between alpha and beta will increase because of presence of an excess alpha gene production. Because you know the abnormality of thalassemia is the imbalance between alpha and beta. When you have additional alpha, it will produce more alpha, and the relative deficiency of beta will become more pronounced because of the presence of this. And this can be identified only by PCR. Dominant thalassemia is another group. Although it is not very common, it's rather rare. The mutations in the third exon, they tend to cause thalassemia-like picture even when they're heterozygous. Then mutations in genes controlling globin gene expression. Well, these are the individuals who would have no symptom of feature suggestive of beta thalassemia, but their children could inherit an abnormality of thalassemia. Well, this is again something which is rather rare. Well, this second group in which there is co-inheritance of thalassemia trait with another hematological abnormality, I think this is more interesting group. We have G6PD deficiency, which is fairly common. When you have a combination of beta thalassemia trait and G6PD deficiency, this will be more pronounced. That thalassemia trait will be more symptomatic or elevated clinical picture. The red cell membrane defects like hereditary spherocytosis or electrocytosis, when this combines with beta thalassemia trait, this also produces sometimes these patients even might get a few blood transfusions. Then congenital disc erythropoietic anemia. This is also seen in our population. I know that probably after thalassemia, congenital disc erythropoietic anemia is the most common cause of transfusion dependency. And heterozygotes of CDA with beta thalassemia trait, they could actually have a more severe picture. Well, I think this was all about beta thalassemia. And let's talk for a few minutes about, is it thalassemia major or not? This is a second scenario. Now, the approach to diagnosis of this child is totally different from what we have already seen, in which we were concentrating mainly on the red cell indices. Here, actually, red cell indices may be or may not be important, but they're not as important as they were in thalassemia. Well, this is the scheme of events. You have to look at the patient, and blood counts, hemoglobin electrophoresis, quantitative estimation of hemoglobin fractions, and other related investigations. But let me tell you that in our practice, at least what I have observed in my practice is that about 40%, 40 to 50% of the patients that come to me with the question whether it is thalassemia major or not, they have already received blood transfusion. And this is a difficult situation. Now, you look at this child. This has features which are so typical of thalassemia major. If from a distance you can recognize, it's all written over this patient that this is thalassemia major. Cases are typical. His abdomen is protuberant because of the massive splenomegaly and whatever. And I tell you, if this child has been repeatedly given blood transfusions, and if you do its hemoglobin electrophoresis and blood counts, you're likely to get a nearly normal result. I think this is the most important point that I would like to highlight over here. That whenever you try to make a diagnosis of thalassemia, especially in children who have been previously transfused, you must look at the patient. In fact, you should always try to look at the patient. Without looking at the patient, making a diagnosis can lead you into trouble. But if you don't look at this patient, if you just examine the blood of this child, you can actually give a normal result. Well, this is why we want to follow this scheme, that you should develop a habit of looking at the patient, or at least if the patient is not available, then at least you should try to ask the question that why this child is being tested. Number one. Number two, whether the child has received any blood transfusion or not, or are the transfusions were multiple or not. I think these three fundamental questions must be asked, or at least you should have an answer to these questions. Only then you should return to diagnose this child. Blood counts, of course, are important because you have to look at it. In the untransfused patient, this can give you a lot of clue about thalassemia. But if the patient has been repeatedly transfused, blood counts may be meaningless. Hemoglobin electrophoresis in the untransfused patient would give you a typical picture. The hemoglobin F is very high. Generally, it is in 90s or something like that. And then quantitative estimation of hemoglobin fractions. I've told you in almost all of the hemoglobin disorders, quantitative estimation of hemoglobin A2 is important. F is not always important. Then sometimes you have to do tests like sibling test and unstable, or similarly, there are other things which are related to this. And when you're not sure about the diagnosis, you might have to resort to PCR in certain situations. In a typical beta thalassemia major, the child generally presents 3 months to 6 months of age. TLC is generally very high. It's not because of anything else, but the presence of high number of pneumoblasts. And sometimes people like to correct that TLC. Then hemoglobin is fairly low. MCV and MCH are typically low. And hemoglobin A2 may or may not be raised because in a young child, generally hemoglobin A2 doesn't go as high as you would expect in an adult. But the hemoglobin F fraction is the diagnostic feature. But if you look at the blood film, this is so typical that you can straight away make a diagnosis, even with electrophoresis. And when you do electrophoresis, you see hemoglobin F. And the quantitative estimation would tell you that this is about 97 to 98%. Now, the problem arises when the child is transfused. Now, look at this one. This child is 3 years of age, has transfusion-dependent anemia. Hemoglobin is low, but MCV and MCH generally they are near to normal. And hemoglobin F is not very high. With a 5.5% hemoglobin F, people would be reluctant to give it a diagnosis of beta thalassemia major because somebody questioned that, how have you made a diagnosis of thalassemia with 5.5% hemoglobin F? Well, remember that this child is transfusion dependent, and all those children who are transfusion dependent, their hemoglobin F tends to get low because of the suppression of endogenous erythropoiesis, which is actually producing hemoglobin F. In such situations. Number one clue is that if you carefully look at the blood film, you will see actually dimorphic film. Now, these are the cells which are normochromic and normocytic, but in the background, you can also see that there are cells which are hypochromic and microcytic. If you carefully look at the blood film, in many patients, you can see that dimorphia. And the second, I think, important point is that if you have a child who is transfusion dependent and you're not sure whether it is thalassemia major or not, look at the blood counts of parents. Now, here you can see that hemoglobin 10.4 grams, MCV is low and MCH is low. This is one parent, and the other parent also has similar parents. Now, a child who is transfusion dependent has both of the parents who are like this. I think most likely, nearly, you can be 99% sure that this is beta thalassemia major, even if the hemoglobin F is not very high. So remember, whenever you have a child with transfusion dependent and you're not sure, is it thalassemia major or not, I think you need to look at the blood of the parents, and you need to develop a habit of looking. Do we need a PCR for this or not? I think this is questionable. At least I wouldn't recommend doing a PCR for this because it's so apparent, both of the parents have got beta thalassemia trait. It would be very unusual that parents have got beta thalassemia trait and the child is transfusion dependent because of something else. Well, I can't imagine that. But people are now have become fond of PCR, so they like to go for PCR. If you have the facility, you can do it. Now, last question, I think, is it thalassemia intermediate or not? I think this is a question which is many times asked, and there's a lot of confusion about it. Now, I want you to look at this history. This is a 7-year-old boy who received first blood transfusion at the age of 3 years. Now he's getting blood transfusion every 6 to 8 weeks. There's moderate splenomegaly. This is history. And hemoglobin is 7.5 grams, and hemoglobin F is 12%. What is the diagnosis? Well, I think if you look at the transfusion dependency, child's age, and then presence of some hemoglobin F, I would be inclined towards the diagnosis of thalassemia. This is thalassemia. More or less, I think you can be sure that this is thalassemia. But what further investigation would you require it, or what are those investigations which actually should be done in this child? Number one, I think the message I want to convey through this slide is that Thalassaemia Intermedia, it's a clinical diagnosis. Remember that. Now people have started doing genetic analysis for thalassemia. I think this is, I rather find it unfortunate. The diagnosis of Thalassaemia Intermedia, it is based on these two features. Number one, age at first blood transfusion. The age at which the blood transfusion started. I think this is a very important question. You must develop a habit of asking these two questions. Number one. Number two, interval between two blood transfusions. If you have an answer to these two questions, you can make a diagnosis of, if you're suspecting thalassemia and if you see these two features, the child started transfusion late and the interval between two blood transfusions is fairly long, you can make it straight away a diagnosis of thalassemia intermedia. You don't need anything else. Blood picture may be exactly like beta thalassemia major. There may be no difference between the blood picture of a child with thalassemia major and thalassemia intermedia, except that hemoglobin might be slightly higher in thalassemia intermediate. Electrophoresis again is not the deciding parameter. Many times I've seen people questioning that when hemoglobin F is low, they tend to see that this is thalassemia intermedia. Well, this is not like that. You can have a low hemoglobin F in many different situations, and not all thalassemia intermediates have hemoglobin F which is low. So in classic delta beta thalassemia, which is a typical presentation of thalassemia intermedia, you can have 100% hemoglobin F. So it is not a blood picture, it is not even the electrophoresis which gives you the clue, it is a clinical picture, I think, which gives you the answer. Finally, genetic analysis. I think people are now getting prone towards getting a mutation analysis for thalassemia intermedia. Well, you can make a prospective diagnosis, even intrauterine diagnosis can be made based on these genetic features, but generally they should not be required. Now, the question of hydroxyurea has arisen in thalassemia intermedia, and people think that probably genetic analysis could actually help you predict in response to hydroxyurea. Well, I don't agree with that. Generally, patients with thalassemia intermedia, they tend to respond to hydroxyurea, you know that, and it's one of the drugs of choice. But for that purpose, you really do not need this mutation analysis. I think this is a very long way. But the shortage of time, I would not pick up that anymore. But there are other features as well, other than these XMN1 polymorphism, mutation analysis, gene status. For example, you can have other quantitative trait loci and then delta thalassemia, so on and so forth. So there are the genetic picture or the profile of thalassemia intermedia is very, very complicated. I think there's not enough time. And I think this is all about the overview of diagnosis of thalassemia intermedia. If there are questions or comments, I'm here to answer those. Thank you very much.
So one question from Dr. Khizr Abdullah Khan is, can you please explain to us about the secondary modifiers in thalassemia patients?
Well, secondary modifiers, I just told you that the most famous one is XMN1 polymorphism. Primary modifiers, हम उनको कहते हैं जो which are the defects in the gene itself. Mutation है, like वो severe हो सकती हैं, कुछ non-severe हो सकती हैं. But there are factors other than these mutations which are outside this, and they're called generally secondary modifiers. XMN1 polymorphism is one which can actually modify the picture of the B-thalassaemia mutation. BCI2 polymorphism is another one. There's a third one which I don't exactly remember at the moment. But generally, these secondary modifiers, they tend to control the production of hemoglobin F in a particular patient. For example, XMN1 polymorphism. When this is present in a homozygous form, this would induce or would preserve the capacity to form hemoglobin F. So these patients tend to have higher hemoglobin F levels in spite of the presence of a very severe mutation in the beta gene. And this hemoglobin F tends to compensate for the absence of it, hemoglobin A production. So this is what it is about.
Thank you. The second question, sir, is from Jawad Jalil, and he asked, can you explain the exact indication for genetic analysis?
Sorry, I didn't get that.
Can you please explain the exact indication for genetic analysis?
Okay. Thank you very much for this question. I think very relevant question. The genetic analysis for thalassemia, I think the most relevant indication is that we use it in prenatal diagnosis. In this country, unfortunately, prenatal diagnosis के लिए इसको कम इस्तेमाल किया गया है और इसको बाकी फजूलियात के लिए बहुत ज़्यादा इस्तेमाल किया गया है. अभी I'm really मतलब थोड़ा सा मैं I find it very interesting कि दोनों सवालात ही जो होते हैं ना वो genetics के बारे में. People are less inclined towards the conventional diagnosis of thalassemia. Nevertheless, I think prenatal diagnosis you cannot make a diagnosis without genetic analysis. Number one. Number two, when the child is transfusion dependent and you're not sure whether it is thalassemia male or not, sometimes we like to use PCR for that purpose. And number three situation could be that, for example, I talked about silent carriers of thalassemia. They can't be diagnosed without PCR. CAF1 mutation cannot be identified by any other means than PCR. Then alpha thalassemia, I think this cannot be diagnosed without PCR. Hemoglobin H disease is one in which we can actually make a diagnosis even with the phenotype. But for alpha thalassemia trait, one gene deletion or two gene deletion, you have to do PCR. Then delta beta thalassemia is another one in which you can confirm your diagnosis by doing PCR analysis. Last but not the least, I think I really do not like that subject. Hydroxyurea के लिए genetic analysis किया जाए, I think it's a total waste of money. और उसके लिए अब ये clinicians हैं या pediatricians हैं या people dealing with thalassemia and hydroxyurea, they've become very fond of doing mutation analysis और उसके लिए उसको पैसा waste करते हैं. But I'm sorry to say I don't agree with that. Diagnosis of thalassemia intermedia is its clinical diagnosis. उसके लिए आपको genetic analysis करने की जरूरत नहीं है. It's misnomer के लिए ये mutation जो है ना ये hydroxyurea को respond करती है और ये mutation नहीं करती है. No, this is complete nonsense. I hope I answered the question.
Two more questions. One is from Saima Iram. She asked, can thalassemia intermedia take a form of beta thalassemia major if not treated properly?
Sorry, I'm sorry. I इसमें थोड़ी सी resonance है जिसकी वजह से मुझे question कई दफा exactly नहीं समझ आता. Can you repeat it?
Sorry, I'll repeat the question if I can.
Please.
Can thalassemia intermedia take the form of beta thalassemia major if not treated properly?
Okay, now I get it. Thank you very much. This is another very relevant question, I think. All thalassemia, they tend to get more and more severe with passage of time. Remember this, whether it is thalassemia major or it's thalassemia intermediate. The reason is that, especially in thalassemia intermediate, this happens because we are keeping the patient off transfusion. And when you keep the patient off transfusion, the hemoglobin tends to remain on the lower side. And when the hemoglobin is low, erythropoietin is produced because of the response of anemia. And this erythropoietin actually stimulates marrow, and marrow gets hyperplastic, and it gets expanded. In a child with thalassemia intermedia, actually the volume of marrow is much larger than a patient who is well-managed thalassemia. Because of the expansion of the marrow, and at the same time, there is also enlargement of spleen. A lot of blood actually pools in these spaces. And with the gradual expansion of the marrow cavities and enlargement of spleen, more and more red cells are actually pooled in this. So all thalassemia intermedia, or for that matter, even thalassemia major who are mismanaged, they tend to get worse with passage of time. So a child, let's say, at 3 years of age, who is transfusion independent, at 7 years of age, may not be transfusion independent. He would require blood transfusion. This is what normally happens. And the only thing which can actually check is in thalassemia intermedia, we know that we deliberately don't want to give blood transfusion. And that's why their severity actually gets worse and worse. In fact, their stage would come that all thalassemia intermediates would become thalassemia majors. Yes, I agree.
Thank you. Dr. Mehreen, over to you. I was just helping in between.
Sir, thank you very much. It was a very excellent presentation, and I hope it was audible to all the participants, and you have put everybody wiser. So people are appreciating in writing that it was a very nice session, and they've definitely learned more. So we should move on to the next speaker. So I'll request Professor Dr. Syed Mohammad Irfan to educate us about transfusion support in thalassemia. Over to Sir Irfan. Thank you, sir.
Okay, good morning, everyone, and thank you very much. My talk is on blood transfusion in thalassemia. This is a usual practice which we come across in everyday's job, and there are many guidelines available to follow. What I'm going to talk is the common problems which we face while making transfusion in our setting. Now, the most important thing before starting transfusion is that you need to be sure about the diagnosis that patient is having thalassemia. And again, the most important point, as General Syed said, is you need to differentiate between intermedia and major. There are no diagnostic tests. It is all clinical, as he said. So any child, age around 8 years, hemoglobin around 7, family history may or may not be there, and comes to you with a picture or Capillary Electrophoresis suggestive of thalassemia, be careful, it may be intermediate. We will talk about it further. Now, Hep B vaccination is routine, but still many children are still not vaccinated for hepatitis B, and maybe at the time of registration we need to check. Extended red cell antigen typing is important. That will save you from future hassle, because alloimmunization is common in intermedia and in major also, in sicklers also. Something around 20 to 30% children develop antibodies, mainly against capital C, capital E, and K. So their red cells should be tied. Another important point is spend some time with the family in the first 2 visits. If you spend some time now, that will make your life easy in future. Tell them the process of registration, process of transfusion, associated issues, availability of blood, delays, timing, and issues associated with blood transfusion. That is very, very important. Having a diagnosis of transfusion-dependent thalassemia is not a good news for the family. You need to prepare them to save some amount. They need to spend some amount of their income on the management of this child. So if you prepare them, it is good. Family planning is important at the initial visit, because if somebody has got 2 or 3 healthy children, they should stop further children. No, because thalassemia is a big financial burden. Now, what is the goal? Goal is different. Unlike many other chronic thalassemias, where your goal is to improve the HB, treat the underlying cause, and that's all. In thalassemia, the goal is different. We transfuse thalassemics to suppress their ineffective erythropoiesis. The hyperactive bone marrow in the thalassemic need to be suppressed. Why? Because it is this ineffective erythropoiesis that is going to give rise all the complications, including splenomegaly and thalassemic phases and other complications. And also, if you suppress this activity and bring their hemoglobin to around 10, then they are likely to have normal growth, development, and activity. That is the clinical goal, and that is the pathology. Sorry. Now, what to transfuse? Obviously, it has to be packed cells, but still many patients in remote areas, in far-flung areas, are transfused with the red cells, and many with the family, directed donations and family donations. So that need to be stopped. No family donors, no whole blood. It has to be packed cell. You already know what quantity and when to transfuse and what should be the duration. I'm not going in that detail, but a few special products. Washed red cells are helpful in patients who develop allergic reactions, which are not uncommon in thalassemia. And in our time, we used to do manual saline washing. Now automatic cell washers are available, and they are good than the manual. When you do manual washing, you usually about 10 to 15% red cells are lost. Apheresis RBC, you can extract 2 packed cells at a time. The advantage is minimal alloimmunization. Cryopreserved RBCs are good, probably not practiced in our setting. I'm not aware, at least. They are good for rare group patients like Bombay group and others. Irradiated RBCs is not a routine, but obviously into patients candidate for transplant or post-transplant, or if somebody is insisting on that family donation from the sibling or first cousin, their RBC need to be irradiated. I am not sure, but I believe in thalassemics, blood should be irradiated in routine to minimize the risk of alloimmunization in future. But I'm not sure whether literature is in favor of it or not. Neocytes are the new and young red cells. They give a modest increase in hemoglobin, but that is not a standard recommendation. Now, this is a very debatable situation, that when patients should be transfused. What should be the pre-transfusion hemoglobin and what should be the post-transfusion hemoglobin? Post-transfusion, I agree, it should be something around 14, because higher hemoglobin may be an indicator of polycythemia. But pre-transfusion hemoglobin, initially TIF recommended hemoglobin of 10, and now it is more of around 9. But I believe instead of focusing on 9 or 10, it is better to focus on the clinical features and clinical behavior of the patient. So some patient with hemoglobin of 8.5 may have no features of ineffective erythropoiesis, like thalassemic facies or spleen or cytopenia. So they may be quite comfortable with hemoglobin of 8.5. So instead of loading them with blood and bringing their hemoglobin to 10, it's better to go according to your clinical judgment. And if they are not having features of ineffective erythropoiesis, they may be maintained at hemoglobin of 8.5. While others who are having these features of ineffective erythropoiesis, even at a hemoglobin of say 9, 9.5 or 10, you may consider a target of something around 10.5 or 11. So instead of simply following the hemoglobin of 9 or 10, it's better that you first look on the clinical features of the patient and you make your decision accordingly. Now, another common problem which we come across is whether we can give 2 units of blood in one day or not. It is always possible. And in developing countries, I would suggest many of our patients, for example, in Karachi, about 30–40% patients come from far-flung areas of Karachi or from interior of Sindh. Why not? 2 units should be given. This will reduce their traveling cost, their misery, time off from the school, and hospital expenses and everything. Wherever possible, 2 units should be given, but make sure that post-transplant HB should not go about 14–15. Also, many patients are severely anemic. They are also candidates for 2 units of Paxil, but make sure that they are not in having cardiac failure or that cardiac failure is not precipitated. So the option of 2 units of blood at a sitting at one day is a good option in our setting. Now, another question is, should filters be used in every case? In our setting, as far as I know, filters are minimally used in thalassemia patients. Their best utilization is right from the first day when they receive the first unit of blood. You must counsel the family about it. One filter cost, additional cost about 3,000 rupees. At least those who can afford, they must get it. There are 3 ways of filtration: pre-storage filtration, which is widely practiced in the world. Every blood which is stored in the blood bank is filtered before storage. So irrespective of the disease, the blood utilization is there without leukocyte. Pre-transfusion filtration is another something which is also done in the blood bank. In our country, it is usually the bedside transfusion, bedside filtration which is practiced. I wish at least those who can afford, they should get filtered blood right from the beginning. Once they develop alloimmunization, then perhaps filters will not be that effective. Advantage is mainly all complications associated with alloimmunization and presence of leukocytes can be reduced. Now, two major issues during follow-up which our patients come across is the availability of timely blood and adequate blood. This is a major problem because most of the centers are unable to meet the requirements of the registered patients. And the second problem is from the patients and the families and especially the mothers and young thalassemic. So why I'm not able to maintain hemoglobin? So these are 2 separate questions. So this, I would request that centers dealing in the thalassemia, they should have some strategy, some better strategy to increase the blood availability of blood. They need to have more donors, more attention, etc. Now the causes of not adequate increase in hemoglobin are multiple, and one patient may have more than one cause. Typical causes are hypersplenism. Then patient may have autoimmune hemolytic anemia. There may be alloimmunization. You need to do antibody screen. You need to do direct test. Some patient may have PRCA. We don't know. Some patient might have developed plastic anemia. It's common with hepatitis C. There may be other causes also. At least we need to rule out whatever we can. Psychosocial support during follow-up. Most of the families appear disgusted during follow-up. They are not happy with the tone of the doctors and the behavior of the thalassemia centers. I know every institute is overburdened, but still this is our job to be nice to them and to minimize their risk. Growth and adolescence are special issues. So probably we as hematologists are not the right people to tackle this. We need to counsel the family and refer them to endocrinologists. Blood transfusion reactions are well known to you. I will not go in detail. The commoner reactions are allergic and febrile, which are manageable with washed red cell or with pre-medication. About 10-15% people with chronic transfusion develop febrile non-hemolytic transfusion reactions. Anti-allergic or Panadol will work. Steroids can also be given in certain situations. बाकी जो बातें हैं HLA, etc., वो probably not practiced here. Another important thing which we can rule out at least is the alloimmunization and autoimmune hemolytic anemia. And here, autoimmune hemolytic anemia is a condition where there is a place for steroids, and I have seen thalassemia patients have been started on steroids by our respective colleagues. This is a good approach, and some patients do respond to it. Other complications are well known, iron chelation, etc. I mean, now, quality of life and blood transfusion. You know, thalassemia itself is a chronic disease, and transfusion itself is also a chronic problem. So, one must have session with the parents, and जब बच्चा बड़ा हो जाए बच्चे के साथ भी must spend some time, maybe in 4-6 months, to tell them to minimize their risk. Sustaining hope and optimism is key, and that is very, very important. Maybe psychologists or some social workers can be inducted in this center, and this is a major part which probably we are unable to take. We are more focused for blood transfusion. We are not associated with psychotrauma, which these patients and families face. Over time, you need to prepare the family for iron chelation. I've already talked about it, and it's very, very important because iron overloading is one major cause of death. Importance of balanced diet remains to be highlighted again. Most of our thalassemics, especially those coming from the rural areas, they are not in good health. We must advise them good diet. You know, something like dahi and makhan and maybe banana. They are cheap stuff and egg, etc., and they will improve the quality of life. Normal lifestyle advice and schooling is mandatory for every children, and parents association should be established, in my opinion, in every thalassemia center, and they should have regular meeting, their own, and with the center in charges every year or every 6 months. This will ameliorate a lot of problems and will generate a lot of hope among the families. Now, another question which parents ask is the life expectancy, which in my opinion is not very good in our setup. Life expectancy is directly dependent on the adequacy of transfusion. For 4 years, we will maintain hemoglobin good iron chelation, life expectancy can go to up to 35, 40, and 45. Most of our children are in between. So majority have hemoglobin something around 7 and 8, and life expectancy is something around 12 to 15 years. And remember, cardiac complications and infections are the major cause of death in children. Thalassaemia Intermedia, suffice to say, don't miss the diagnosis. General Syed has already talked. My message is simple. There is no age for Thalassaemia Intermedia. They can present you at around age of 8 months. They can present to you at around the age of 20 years. I remember a young boy around age 20 from GRC. He presented with paraparesis. He was admitted in the medical ward. A lot of work was done. MRI of the spine showed some deposits. I saw the film. I picked up probably Thalassaemia Intermedia because of some morphological findings. I talked to the physician. We did an electrophoresis done. HbF was something around 98%, and he was never transfused in life. So his presentation was like paraparesis. So intermediate patient can come to you in around age of 8 to 10 months, 12 months. Be alert. Any children with or without family, age around 1 year, hemoglobin around 7, may be intermediate, irrespective of hemoglobin F. There is no definitive correlation between severity, clinical severity of thalassemia and HbF. So remember this. Indications for treatment in Thalassaemia Intermedia. This is a heterogeneous group, and some people may need treatment at early age, maybe 2 years. Some people may not treatment even in late age, they remain undiagnosed. Now, some people may need treatment at middle age, as I told you about the case of paraparesis. Indications for treatment are simple. In pediatric age, it is the retardation of growth and height and etc. etc. Growing splenomegaly is another indication. Cytopenia is another indication. Thalassemic phases and other features of ineffective erythropoiesis are other features. So growing anemia is another feature. There may be 1 or 2 more features. But if these features are there, then probably this is an indication for some treatment. In some cases, treatment may be required on regular basis, like Thalassaemia major in time to come. Or in some cases, it may be occasional transfusion that may be very helpful. We have to be very tricky in the management of thalassemia. What I have seen in pediatric population especially is that if somebody comes to you at around the age of 1.5 years, 2 years, and with hemoglobin of 6.5, 7, 7.5, if you simply put them on folic acid, the HB rise is from 1 to 1.5 grams. That is another therapeutic test supported by your electrophoresis and morphology that probably this was thalassaemia intermedia, and probably he was folic acid deficient. HB has gone up and patient symptoms also decreased. Now you can decide to have any further long-term treatment in addition to folic acid or not. The decision lies between hydria, splenectomy, and transfusion. I'll not go in detail. It is best to avoid transfusion, but do not compromise on the indications I've already told you. Hydria is a very good option for thalassemia intermedia. Splenectomy is also a good option as a one-time treatment, particularly if somebody is maintaining hemoglobin of 8 or with some features with some indication of thalassemia. Maybe splenectomy will bring their hemoglobin to 9, 9.5. Best to avoid transfusion and hydria. We will talk about hydria in the next slide. NTDT is a new term which is used for beta thalassemia intermedia, E-beta thalassemia, and 3-gene deletion alpha thalassemia. Now, what are the drug therapies for minimizing transfusion in thalassemia? Hydria and EPO are mainly indicated in thalassemia intermediate. Their role in major is debatable, and maybe in future we may get something for thalassemia major also. But hydria has a definitive role in intermedia. Some 35 to 40% patients do respond to hydria with an increase in hemoglobin from 1.5 to 10%, which is enough to bring hemoglobin to a level where patient can have a normal life. EPO has also a role in thalassemia intermedia, but probably it is best avoided as a single therapy. There is emerging data that hydria and EPO can be combined, and their results are better. So it's personal choice also. Now, transfusion and splenectomy, I'll not go in detail. Splenectomy is not a bad option in our setting. In thalassemia major, it may reduce the transfusion, the gap maybe improve between the blood transfusion, but it's just minimal, maybe 4, 5, 6 days to a week or so. It should be a well-planned procedure. If at all you decide, you must vaccinate the patient at least 2-3 weeks before the planned surgery, because it is antibodies take time, 2 to 3 weeks, to develop against the vaccine which we give to the splenectomy. Post-splenectomy prophylaxis is probably not done anymore in the Western world, but in our setting it is important that we do give post-splenectomy prophylaxis. 2 to 5 years is the recommendation. It may be erythrocin, it may be amoxicillin, it may be penicillin B, or it may be something else. And it is very, very important that you educate the patient about the risk of infection and that they should report for any fever above 100 to your ear. Now, thalassemia and pregnancy, this is again a sensitive issue. Pregnancy is always possible, particularly in well-managed thalassemia. Anyway, pregnancy is always high risk, but most outcomes are favorable. Evaluate for eligibility. If patient is interested in having pregnancy, you must evaluate for eligibility, and you must have an extensive workup. Revive all the medications. You need to stop certain medications like hydria and bisphosphonate. Multidisciplinary team is to be involved. HB has to be maintained at 9 or above, even if it is thalassemia intermedia, which you have been maintaining at hemoglobin of 8. But if she becomes pregnant, HB should be above 9. Single most important cause of problems in pregnancy in thalassemics is the cardiac issues, particularly those who are already iron overweight. And you can always encourage breastfeeding after delivery. Now, what is new in thalassemia? Not much to tell you. There are more options for patients who can have transplant. For example, haploidentical transplant and unrelated donor transplants are giving as good results probably as a sibling donor transplant. Gene therapy, as you know, is in the way, but it's far away from wider availability for most patients who are thalassemia major. New drugs are in the market. There was an article about a few months back in the NIBMT about these drugs that this modestly increases the transfusion gap between in certain selected groups of patients. I have no experience, and probably this is not available, and if it is available, it will be an expensive drug, but let us hope. Now, what is the impact of COVID-19 on the thalassemia management? It has really affected the thalassemia patient, the thalassemia center. There is shortage of blood because of the lockdown. The visits of the thalassemics are hampered. Availability of blood is a problem. Staff management is a problem. Cost is also a problem. So this is not a good news for thalassemic patients, but we should try. since we have to live with it, we should devise strategies to minimize the troubles of thalassemic patients and families. One thing is clear, that this disease is not transmitted through the blood. This is the good news so far. But any thalassemic who comes with upper respiratory tract symptoms or other febrile symptoms must be seen with a high index of suspicion, particularly sickle cell patients who may be hyposplenic also. Some patients with thalassemia are at larger risk, maybe those with cytopenia, and definitely those who have got diabetes also, and maybe those who have recently been transplanted. As I know, splenectomy does not confer increased risk to viral infection. This is a good news, but again, this is debated. What we should do, we should continue the same transfusion and chelation in these thalassemics as before. And we must have distancing, mask, and hand hygiene in our centers, availability of sanitizers, and a mask can be done by the center if they can afford, or otherwise patients should be educated. Transplants are typically deferred in the routine in thalassemics, but can be done in emergency cases. With the patient and family in the beginning and intermittently also. Two most important aspects of management and a good outcome are adequate timely transfusion and adequate chelation. Third point is Thalassaemia Intermedia should not be missed and it should be managed differently. And fourth point is that the burden of COVID-19 is tremendous, and that burden we should share among ourselves, and patients should not so. Thank you very much. Thank you.
Thank you very much, sir. It was indeed a very comprehensive presentation with a very nice take-home message. And yes, definitely transplant should be deferred for thalassemic. Center working on leukemia and those who are about to relapse. So we should not consider about the transplant of thalassemics who can carry on with the transfusion, and after this COVID-19 is over, will be going for their transplants. Thank you very much. We all are learning to use this Zoom cloud, and this for the information of all the participants, this live session would be available on Facebook. And questions are coming. I don't know whether they have verbal questions or whether the panelists can answer the verbal questions, because the written questions I can see from the participants. So we should, I think, move on to the next panelist. I would like to have the honor to invite Professor Dr. Adil Akhtar from Lahore. He is, as I've already explained, a consultant pediatrician with special interest in thalassemia. And I must tell the audience that he has written the guidelines, second edition of iron chelation therapy for thalassemics from Pakistan Thalassaemia Federation. So thank you very much, Sir Adil. Over to you for pathophysiology, consequences, and management of iron chelation. Thank you very much for being with us.
Thank you so much. I'll be, hopefully in the next 20 minutes or so, be talking about iron chelation management. And what I'm going to hope to do, I'm sorry. Yeah, some of my learning objectives will mainly be, hopefully after this talk, the participants will be able to describe the pathophysiology of iron overload, be able to identify some of the complications of iron overload, and most importantly, be able to choose the right drug in the right dose and for the right patient. And I think that's probably the most important takeaway from here. Now, one thing we have to understand is, like our previous respected speakers had talked about, one thing is the blood transfusions, but on the other side, which is extremely important, is making sure that patients can get the iron chelation therapy which they require, as the body really does not have any natural mechanism to excrete the additional iron that blood transfusion confers. Now, keeping in mind that across different there are different genetic variations. And just if you can see my laser pointer, this shows a study which was done which shows the overall myocardial iron deposition, what happens in the West, what happens in the Middle East, and what happens in the Far East. And you can see that there are significant variations. So this just talks more into what we had previously been spoken about, secondary modifiers and tertiary modifiers. The genetic sequencing of thalassemia is much more complicated than we think. And part of that also is responsible for how iron is deposited into the heart and the liver. And you can see how variation occurs in the liver iron deposition as well. Now, can we have iron overload in the absence of any transfusions? The answer to that is yes. There was a mention about non-transfusion dependent thalassemia, which may be a wide variety of your E-thalassemia, it could be your delta beta thalassemia, it could be any of the thalassemia syndromes which do not necessarily need transfusions to survive, but may maintain themselves at very low hemoglobin levels. But what happens is when these patients maintain these very low hemoglobin levels, iron accumulates due to the increased intestinal absorption. Just to give you an example, under normal circumstances, your iron absorption is approximately 1 to 2 milligrams per day. Whereas when patients are significantly anemic, that results in maximum stimulation for iron absorption, and the iron absorption may reach anywhere between 3 and 5 milligrams per day. In the presence of transfusions, obviously we know that one packed red blood cell bag usually contains approximately 200 milligrams of iron per unit, and patients receiving 2 to 4 units of blood per month can get an annual accumulation of about 5 to 10 grams of iron. Now, just this brief diagram will actually demonstrate on how these iron chelators actually work. And a majority of the iron chelators, which include desferol and D-ferrocerox and D-ferroprone, all target the labile pool of iron. This labile pool of iron is the one that is most toxic. But you can see that this is a dynamic phase where iron keeps on moving from the intracellular to the extracellular region, as well as keeping in mind that when you have a large labile pool of iron, this results in reactive oxygen species, which can cause significant damage to all of your cell components. The organs which may be affected are obviously the pituitary gland, which results in significant growth hormone disturbances, where we typically see our thalassemic children not able to achieve the height which our normal children may be able to. It affects the adrenal gland, it affects the liver, obviously, the endocrine organs, the sexual organs, including the testes and the ovaries, which result in delayed secondary sexual characteristics and delayed maturity or puberty. It affects the pancreas, the heart, and the thyroid. And keeping in mind all of this, one of the most common reasons why children die is because of cardiac iron overload. Now, what chelators do we actually see? When we look at the chelators, we now have 4 different chelators available in Pakistan. We have D-ferrocerox, which comes in 2 forms now. It comes as a film-coated tablet, and it comes as a dispersible. Then we have D-ferroprone, as well as desferrioxamine. Now, all of them are oral except for desferrioxamine. The dosages are right here. I just want to highlight that the film-coated D-ferrosirox tablet has a lower dose of D-ferrosirox when compared to the dispersible tablet. Just when we look at the schedule, obviously D-ferrosirox is once a day, but D-ferroprone is at least 3 times a day. One of the biggest mistakes which usually non-compliance to it, excess of vitamin C, so a lot of patients are prescribed CAC 1000. That contains at least about 500 milligrams of vitamin C, which is much higher than what you would like to recommend to patients with thalassemia. It may be because of an acute flare-up of hepatitis, acute infections, or obviously lab errors. Now, whenever you start a drug, in order to ensure that this drug is well tolerated by the patient, you would like to start at a lower dose. And the starting dosages are recommended up here, as well as how you escalate these medications to the maximum recommended dose is also given right here. One thing I would highlight over here is it is of no use if you maintain a patient on low doses of iron chelators. You need to provide them with optimal dosages, otherwise they will continue to maintain a very high serum ferritin level and a very high iron overload. Now I'm just going to go over some case scenarios which I hope will be useful for you to remember how to use these guidelines. So Aslam is a 5-year-old known transfusion-dependent thalassemic child who presents to you with 4 iron chelation. The serum ferritin level is 2000. Now, how do you actually go about choosing which is the right drug to use? And this is where our guidelines come in handy. So the dark red indicates that this is the treatment guideline for transfusion-dependent thalassemia. This may be the first visit, as long as the child is over 2 years of age, has received 10 to 20 transfusions, or has a serum ferritin level of above 1000. This is the flow chart which you would like to use. If the child has a serum ferritin level of less than 1000, you would be using the lower dosages of the iron chelators, whereas if the child has a serum ferritin of between 1000 to 2500, you would be using higher doses of the iron chelators. And that's the important point. If the child has a higher ferritin, higher dosages. Now, our same patient, Aslam, has been regular with his treatment for the last 2 months. His parents are eager to see whether he's improved in his iron overload, but Aslam has recently been suffering from a common cold and hopefully not COVID, and has now recovered. So his parents go ahead and get a serum ferritin. Important to keep in mind here is that once a child is suffering from any common cold or any infection, because serum ferritin can also be acute phase reactant, this may be falsely elevated. So this is probably not the right time to get his serum ferritin level and use that to tailor how his iron overload is progressing. Now, 6 months since the start of Aslam's iron chelation, he's now at 2400. So he initially started at 2000, a serum ferritin level of 2000, and now he's 2400. There's an increase of about 400 nanograms per, this should be deciliter, and the parents are disappointed at the response of the iron chelator. Keeping in mind that if there's there isn't a rise of greater than 500, you can actually continue at the same dose and repeat the serum ferritin level at 6 months. But if there's an increase of greater than 500, then you would use maximum dosages of the iron chelator medications. What you see here, 1, 2, and 3, do not necessarily indicate the preference which you do. Remember, when you choose the right drug for any thalassaemic patient, it is essential that you use a drug which the patient is willing to take. You use a drug which the patient can afford. You use a drug which the patient can tolerate, especially considering the side effects, and not necessarily consider what is, quote unquote, the best drug available for iron chelation. Otherwise, you will not be able to have a compliant patient, and the results which you expect may not be seen. Now, let's look at what's happening now. Aslam has been very ill for the last 3 months. He's received multiple transfusions this time. The serum ferritin level is now 3100. What should be his iron chelation regimen now? And you can see how it's progressed: 22,000, 2,400, 3,100. And this is where your combination therapy would be very useful. So whenever your serum ferritin goes across 2,500, you want to use combination therapy. Remember, your goal for chelation in serum in transfusion-dependent thalassemics is really to keep the serum ferritin level below 500. And that's where you would use combination therapy. Notice that your combination therapy can be either D-ferrocyrox with desferrioxamine or D-ferroprone with desferrioxamine. If the child is using hydroxyurea, which hopefully in transfusion-dependent thalassemics they are not, you would not be able to use D-ferroprone. Now, second case, I'll hopefully be finishing up in another 5 minutes, just to save time. Salman is an 11-year-old male who has in the past intermittently used iron chelation, and that's a very common scenario which we do see in our clinics. His serum ferritin level is 4,700. Very clearly, whenever patients have a serum ferritin of greater than 2,500, you would like to recommend that they do use combination therapy. And once they get a serum ferritin level of less than 1,000, you can go on to monotherapy. Case scenario 3, Amna, a 12-year-old who is a non-transfusion dependent thalassemia, has received only 5 transfusions in her life. She maintains her average hemoglobin at 8 grams per deciliter and does tolerate hydroxyurea well. Her serum ferritin level is 624. Now, this is an interesting scenario, the reason being that normally in non-transfusion dependent thalassemia guidelines, which are indicated in orange, you start chelation therapy when the child has received 20 or more transfusions or the serum ferritin level is 800. Now, in this scenario, Amna's serum ferritin is 624. But patients who have not received any transfusions or have received some transfusions will generally need iron chelation at around about 10 years of age. Since Amna is 12 years of age and your target for your serum ferritin level in non-transfusion dependent thalassemics is less than 300, is much lower than transfusion dependent thalassemics, thus you would actually start iron chelation therapy at a lower dose in Amna's case. She's 14 years old now. Her serum ferritin level has started bumping up. Obviously, you would go to a higher dose and then continue and see what happens. Repeat the serum ferritin level at 6 months. I want to point out here that internationally, it's recommended that a serum ferritin level should be checked every 3 months. But considering our patients' capacity, you would prefer that they spend the money on their iron chelation rather than serum ferritin level is 2,600. This is a situation where, again, anytime a child goes over 2,500, you do want to use combination therapy. But notice here with your guidelines for non-transfusion dependent thalassemics, we do not recommend deferriprone, considering that a majority of our non-transfusion dependent thalassemics may be on hydroxyurea. But a caveat in this scenario is that if your patient who is non-transfusion dependent is not using hydroxyurea, you may use deferriprone. Second last slide, I believe, our serum ferritin level. Keep in mind, anytime there's an acute fever, acute phase, it is an acute phase reactant, and thus you should be wary of what the results are. Don't take the results of a serum ferritin level as a hard and fast rule. Whenever you do get a serum ferritin level, please ensure that it is from a reliable lab and that you repeat the serum ferritin from the same lab in order to minimize differences in lab techniques as well as errors. Similarly, remember that you should ensure, you should ensure that you can monitor for neutropenia if you are using deferriprone, and that deferriprone with hydroxyurea should not be used together. One last little point I would like to bring here is the importance of arthralgias, which we do see in the use of deferriprone. Sometimes हमारे पास बच्चे ऐसे आते हैं who are not able to walk, and one of the reasons we see is that they are on deferriprone, and when we stop the drug, their ability to walk returns, because the fact that the arthralgia has gotten better. Thank you very much for being very patient listeners.
So thank you very much for a very crisp presentation with a very clear voice. So our last speaker is from my own institute, Armed Forces Bone Marrow Transplant Center. He is pediatric oncologist and the transplant physician at our center, and he would update you about the transplant outcome, allogenic bone marrow transplant outcome in beta thalassemia major. Over to Sir Tariq Ghafoor.
Well, we are the pioneer in making the history on this forum. So I will speak about the transplant and issues of transplant for thalassemia major. So as you know, the thalassemia major is the most common genetic disorder, and the survival in the Western countries has increased over the last many years because of the better understanding of the pathophysiology of iron load and improvement in the medical therapy. And their thalassemics, they usually survive into the fourth or fifth decade of life. And the hematopoietic stem cell transplant remains the only curative treatment for thalassemia. Just a few slides about the thalassemia in Pakistan. We have about 5% population is the carrier, and total carrier about 8 million. And nobody exactly knows how many thalassemics are born in Pakistan, but the rough estimate is about 5,000 to 6,000, and about 60,000 thalassemics are alive at one time in Pakistan. And thalassemia is the main consumption of the donated blood is by the thalassemics. And if you look at this age group, about 75% patients are between 1 and 10 years of age, and only about 3.3% they survive more than 21 years of age. This is just a graphic presentation. When they after 25, there's hardly any survival in thalassemia in Pakistan. So first thalassemia transplant was done in Seattle in 1981. It was 14-month-old child who was transplanted with her matched sibling sister. And one of the deciding factors for thalassemia transplant are the Pesaro group classification system, which consider three factors, that is the hepatomegaly more than 2 centimeters below the costal margin, then the portal fibrosis on the pre-transplant hepatic biopsy, and quality of the iron chelation. If the iron chelation was started within 18 months of of the blood transfusion and has been done regularly, then it is called regular iron chelation. And if it is started more than 18 months and then have been irregular iron chelations. So based on it, three factors, hepatomegaly and the fibrosis and the quality of iron chelation, patients are categorized three classes. Class 1 where all risk factors are absent, class 2 where 1 or 2 of the risk factors are present, and class 3 is the where all the risk factors are present. Splenomegaly in itself is not a risk factor for the transplant, but it may have a role in the delayed engraftment and increased blood transfusions. And splenectomy may be associated with increased transplant-related mortality. And hepatitis C, because it's again very common in these patients, so there is no evidence that hepatitis C has any influence on the outcome of the transplant in these patients. Hepatitis C and iron overload may accelerate the progression of liver fibrosis, and it is a recommendation that hepatitis C positivity may thus actually strengthen the indication for transplant if proper supportive care is not available. So basically the major input in the transplant and thalassemia comes from the hospital of Pesaro, where they did a study where 515 patients of class 1 and class 2 with the median age of 7 years, with a range from 1 to 16 years they were studies. So conditioning, the basic aim of the conditioning are the threefold rather. Number 1 is to eradicate the marrow, for which they use this busulfan. And second is the immunodepletion or immunomodulation, which they did with the cyclophosphamide. And the third component is the GVHD prophylaxis, for which they use cyclosporin, methylprednisolone, and methotrexate. So with this busulfan and thiotepa, they did the bone marrow eradication of the thalassemic marrow and then the immune modulation. What they achieved, the results were survival was 88% and thalassemia-free survival was 85%. And the transplant-related mortality was 12% and rejection was 4%. But when they came to this class 3 patients with the same dose, the survival, thalassemia-free survival was only 53%, where very high mortality of 39%. To decrease this high mortality, what they did, they continue with the same dose of busulfan, but they lower the doses of cyclophosphamide from 200 to 160 or 120 milligram. This resulted in improved survival from 53 to 79%, but at the same time the rejection increased from 7 to 30%. So for this class 3 patient, to reduce the rejection, protocol 26 was introduced in 1997, which included azathioprine 3 milligram per kg for about 34 days, hydroxyurea 30 milligram per kg, and then fludarabine 20 milligram per kg per meter square for 5 days, 100 in total. Then busulfan, same dose, and the cyclophosphamide 160 milligram total, 40 milligram per kg for 4 days. So this is known as generally known as long protocol or protocol 26. They also use the growth factors GCSF and erythropoietin twice weekly. So with this, the results, they have shown the survival 87% and thalassemia-free survival 82%, and transplant-related mortality 12%, and rejection is 7%. So generally, this is the main protocol used for thalassemia. Then people have done other studies, like they added thiotepa with trisulfan, because trisulfan is a sister drug of busulfan with less toxicity, less incidence of veno-occlusive disease. So this study, they have reported overall survival 93% and disease-free survival 84%. I would be sharing our experience, what we see, because we see very different and unique type of population of patients here and as compared to the Western population or the Far East countries. So this This is data of 298 patients, which includes the first ever transplant done from 25th October 21 to 31st December 2019. And all cases were included, and the patient who had second transplant, they were excluded. So there were mean age of diagnosis was about 10 months, and mean transplant age was 67 months, with the range from 11 months to the oldest was the 16 years 8-month old. 76 patients were less than 3 years of age, and 189 patients were more than between 3 to 10 years, and 33 were more than 10 years of age. The male were almost double than the female. Only 24 patients have regular iron chelation, which just making 8%. And the serum ferritin, about 20% patients are less than 1,000, and the other were more than 1,000, and about 3% patients have more than 5,000 serum iron at the time of transplant. 180 patients have transfusions less than 50, and about 30 patients had more than 100. Hepatitis C was present in 15% of patients. They were treated before going to transplant, and 81% have no iron, no hepatitis C infection. Data was missing in 9 patients. Hepatomegaly, 20% patients have less than 2 centimeters, and majority were between 2 to 5 centimeters. Similarly, splenomegaly was in 42% patients less than 2 centimeters, and the 10 patients they have splenectomy. So the class 1, based on the hepatic fibrosis, iron chelation, and these hepatomegaly, there were only 29% patients which were class 1, 81 patients were class 2, and 188 patients of class 3. So sibling majority of the patients, the siblings, 125 brothers, 152 sisters, so making 92%. And there were 15 parents, 2 cousins. Of the donors, 196 or 65% donors, they were trade. There was 51 patients have a sex mismatch. Blood group ABO matching or mismatching also plays a role in the transplant outcome. So there were 58%, there was no major mismatch, major or minor, and about 17% patients have major mismatch, and the 20% minor mismatch. So with the conditioning, what we used is the one is the typically called as the short protocol with busulfan cyclophosphamide 200, that was used in 102 patients, and the long protocol with hydroxyurea, azathioprine, fludarabine was in 196, almost double than the short protocol. Because we don't usually get the class 1 patients, so that's why the majority of the patients are class 2 or 3, so that's why the long protocol was the main protocol. Stem cell source was bone marrow in about 75% patients, and PBSC in 11% patients. So acute GVHD was in almost 40% patients, and the major other complications are mucositis, hypertension, hemorrhagic cystitis, and hypokalemia because of the amphotericin, which is usually used as the antifungal medicine. 18 patients or 6%, they have veno-occlusive disease, and 100-day mortality was 12.8%. So acute GVHD, we had 118 patients with acute GVHD. Majority of them, they were grade 1 and 2. And there were only 3 patients have grade 3 and 8 patients have grade 4 GVHD. Unfortunately, none of them survived, grade 3 and 4. So just coming to the results now, the treatment-related mortality of the overall 298 patients is 15.6%. And then again, rejection is very high, 15.3%. Disease-free survival is only 65%. And death because of other reasons. Some of the patient, one patient died because of road traffic accident, few patients died of other complications as not transplant related complication, but gastroenteritis or other reason which were not related to the transplant. So overall survival is 80%. So this, if you look at the class 1, we have 79% overall survival, and class 2 is 81%, and class 3 is the 78%. So disease-free survival again is class 1 is the 62%, and the class 2 is doing better, 72%. So this is the treatment-related mortality in 29 patients of class 1, which is 20%, and rejection is 17%. So overall survival is 82% in class 1. Class 2 is the treatment-related mortality is 12.3%, rejection is 9.9%, and overall survival is 82%. And class 3 is again high treatment-related mortality and rejections, and overall survival is 80%. So major causes of mortality were infection 35.4%, then GVHD 13.8%, respiratory failure and primary graft failure in about 10%, bleeding including intracranial bleed or pulmonary hemorrhage, they were 7.7%, venous occlusive disease was 4.5%, and others not related to transplant, they were 16.9%. So just another protocol, because of the high mortality and high rejection in the class 3 protocol, another study reported by Javed in Transplant 2016 was the increased fludarabine from 100 to 150 with addition of thiotepa. And the busulfan cyclophosphamide that remain the same, GVHD prophylaxis remained the same, cyclosporin and methotrexate 3 doses. They have this, they reported is the 92% overall survival as compared to previous protocol of 73%. We did the same protocol in our children, but we had a quite high treatment mortality. In class 1 it was 16%, class 3 again 16.7%. And this protocol resulted in a better rejection prevention. The rejection reduced to 8.3% and 10%. But the ultimately overall survival did not improve. It was 80.8% to 81.6%. Now currently we are using this protocol, which we have used in only 24 patients, which include busulfan 120 milligram per meter square, and then busulfan 16, cyclophosphamide 160, and thymoglobulin 2.5 milligram per kg over 3 days to total 7.5 milligram. If it is a same sex, then we use the 4 milligram. So this result in class 1, there were only 8 patients, so treatment-related mortality and rejection is 0%. 100% disease-free survival and overall survival. And in the class 3 patients, because the number is so small, only three patients they have treatment-related mortality. One because of GVHD, other has respiratory failure, and one child had this primary graft failure because of CMV, and then she died also. There is one rejection. So overall survival is 81.3% in class 3. So this is just the graphic presentation of the same data. The class 2 is 100% overall survival and 81.3% in class 3. Again, class 2 is disease-free survival is 100% and class 3 is 75%. We looked at the different factors affecting the survival. So again, when we're looking at the sex, so female is 80% as compared to male, slightly more than them. And the serum ferritin, though high serum ferritin is thought to be having increased incidence of hepatic fibrosis and may be contributing to the poor outcome, but there's no major difference, no statistically significant difference. The serum ferritin less than 1000, the survival was 80.8%, and more than 5000, it was 77.8%. So only 3% difference. Hepatomegaly, again, more than 5 centimeters had a statistically significant poor outcome as compared to 85% in less than 2 centimeters. Splenomegaly, not a major difference. Interestingly, the patient who had splenectomy, they did well. They were 90% survival with the splenectomy. Hepatitis C infection, not a major difference. Rather, the patient who had infection, they had a better survival as compared to patient who did not have hepatitis C infection. Then blood group mismatch, not a major difference. No mismatch is 77% and bidirectional is 80%. And the minor, they had the best results. Acute GVHD, the patient who had GVHD, the survival was 78%, and with the no GVHD, it was 81.5%. And if you look at the severity of the GVHD, so grade 1, the survival was the best, it almost 90%, grade 2 is 78%, and grade 3 and 4, there was 0% survival. All of them, 11 patients, they expired. So in conclusion, the class 1, they have high mortality, treatment-related mortality and rejection. Class 2, they are doing the best because they have the less 12% treatment-related mortality and 9.9% rejection. Class 3, which have again high mortality and high rejection. In our experience, the thiotepad and fludarabine, they both reduced the rejection, but they were associated with increased treatment-related mortality. So in our experience, hydroxyurea followed by the fludarabine, busulfan, Syed and thymoglobulin protocol has best results in our center. Almost 100% disease-free survival and overall survival for class 2, and 75% and 81% overall survival in class 3 patients.
So thank you very much for sharing such an important data on post-allogenic bone marrow transplant thalassemics. It was really very impressive to go through all the data, and all the participants could be educated with the results. So with this, we come to the end of today's webinar. I think it was a success. So Tariq, there are 7 questions for you on the right upper corner of your screen, so you can answer them. And there's a few questions left from other panelists. Most of the questions have already been answered. So we wish and pray that there are very few transplant centers. So in our country, the non-transplant treatment, especially chelation, should improve all over the country. Secondly, there should be thalassemia registry. And thirdly, last but not the least, as ever, as General Suhaib says, and I being the student of General Suhaib, prevention, prevention, prevention. Prevention is the only answer to thalassemia in Pakistan. If any of the panelists wants to say something, you're most welcome. And then I'll hand over to President, Pakistan Society of Hematology, General Parvez, for the concluding remarks. Thank you very much, everybody. I express my gratitude to all the panelists as well as all the participants for sparing their precious time on Saturday morning. Thank you very much, sir. Thank you very much, Jan Suhaib, sir. Thank you very much, Sir Irfan, Dr. Adil, and Sir Tariq Ghafoor. Thank you very much. If no one among the panelists wants to have some comments, then General Parvez can take over for concluding remarks.
You asked for answers to some of the questions that people have put on. We want Dr. Tariq Ghafoor to give answer to the questions.
Do you want me to this? Okay, because they were written questions, so I was trying to answer them on the screen. So first question is from Dr. Jawad Jalil. The most common cause of mortality is infection. What were the most common infections and what is being done to reduce the infection? So because these patients, they have a neutropenia about 2 weeks minimum, sometimes 3 weeks. So gram-negative bacteria, pseudomonas, or Klebsiella, they are the commonest organism we see routinely. And we give them the best possible treatment. But unfortunately, because of the, as you know, the unjustified use of this meropenem, as every patient, maybe some patient with just cough and cold, they are getting meropenem, and which we are left with very limited choice of antibiotics. So our first line in pediatrics is still the tazobactam and amikacin, then followed by the meropenem, and third line we usually go to the colomycin. I don't understand, I don't know what will be the fourth medicine in my hand, because these are the neutropenic patients. So other is the hygiene and the hand hygiene and the sanitary measures which we adapt for the patient. But the gram-negative infection, they usually come from the gut of these patients.
So thank you very much.
Yeah. Next question was Dr. Muhammad Mansoor Beg. There is only one line. Could I ask Dr. Ghafoor? But there is no question. Yes, sure. You can ask whatever you want to ask. Dr. Muhammad Mansoor, the TRM in all three Pissarro group is almost same at AFBMTC. There's no specific reason, because we see what we see is the our patients, as I mentioned, there is the, because this study which I presented data is almost 20 years, so there are different phases. As I mentioned, in the for the last few years we have become more wiser, because we have been doing this experiment by increasing the doses of different medicines, such as fludarabine was 100, then 120, then 150, then we added 30 per. But the problem in this country is we don't know, 30 per sometimes became available, sometimes it was not available. And there was a time when we had this busulfan which was supplied, and that was expired. Later on we investigated, and we lost about 6 patients. They had rejection. And then at the present scenario, we are buying this busulfan which comes from India. Still we don't know, despite all the assurance from the pharmaceutical company, whether the temperature was maintained or not maintained. So this is the basic problem, that the availability of the medicine, the conditioning medicine, is not very reliable, because they are not manufactured in Pakistan. So it's become difficult to comment to what was the problem and where was the problem. So in short, we think the best treatment group for the transplant, to go for the transplant in thalassemia, is the children between 4 to 5 years of age, which is a class 2, well chelated, and they are doing the best, almost 100% survival with this latest protocol we are using. For the VOD, there was a question, what is the approach to VOD prophylaxis? We are using the urso deoxycholic acid as the prophylactic. Defibrotide again is very expensive, so we have used in few patients. We have 6% patients, about 11 patients with VOD, and 4 or 5 of them they were managed with supportive care only, and 3 patients we used this VOD. Again, it's very expensive. About 20 kg patients, they cost about 1 million for the treatment with the defibrotide. So again, we are doing this transplant about 2 million rupees. So it's become very difficult for the family to arrange for the defibrotide. And we lost 3 patients with VOD, though did not receive any specific treatment. They were just kept on supportive care. I think these were the all questions I have answered.
Thank you very much. Professor Irfan mentioned haploidentical transplant. I just wanted to answer this thing, that haploidentical transplant is an option, but in our center we have not opened the gates for haploidentical transplant. So I would request Jana Parvez Ahmed, President, Pakistan Society of Hematology, for the concluding remarks. Thank you very much, everybody.
Thank you very much, Mehreen. It was a great success, alhamdulillah. And this was the beginning, though we had some short hiccups that fortunately settled. And it was a great success and good participation by everybody. We have received appreciation on our in the PSH group as well, for you especially. And I hope to continue such activity. Inshallah, we'll come up with the detailed program of these webinars and spread over next 1 year, inshallah. And we would request you to actively participate and encourage your juniors for these academic activity. Thank you very much.
Thank you very much, everybody. I should announce on the behalf of President that the next topic in July is hematological aspects of COVID-19, which would be very interesting for all of us. And suggestions and comments from all the participants are most welcome. Thank you very much, everybody. And lots of thanks to all the panelists for sparing their time and the participants for attending it so actively. Thank you very much. Assalamu alaikum.